Understanding hypertension, causes, treatments, and the hidden risks. Hypertension, more commonly known as high blood pressure, is one of the most pervasive yet often underappreciated health conditions globally. Affecting over 1 billion people, it is a leading risk factor for heart disease, stroke, kidney failure, and premature death. Despite its silent progression, hypertension is far from benign. Left unmanaged, it quietly inflicts damage on the cardiovascular system and vital organs. The key to controlling hypertension lies not just in reducing the numbers on a blood pressure cuff but in understanding its causes, complications, and the nuanced approaches required for effective long-term management. The hidden toll of high blood pressure on the heart. One of the most concerning consequences of uncontrolled hypertension is its damaging effect on the heart. Over time, elevated blood pressure forces the heart to work harder to pump blood against increased resistance in the arteries. This chronic strain leads to structural and functional changes within the heart, particularly the left ventricle, which is responsible for pumping oxygenated blood to the body. Initially, the heart responds by thickening its muscle wall, a condition known as left ventricular hypertrophy, LVH. While this adaptation may help in the short term, the thickened heart muscle eventually becomes stiff and loses its ability to relax properly between beats. This impaired relaxation, or diastolic dysfunction, is an early step toward heart failure. In more advanced cases, prolonged hypertension contributes to myocardial fibrosis, microscopic scarring of heart tissue. These fibrotic changes reduce the heart's flexibility and interfere with its ability to fill efficiently, further exacerbating heart failure symptoms. The stiff, scarred heart may also struggle to pump effectively, especially during exertion, and can trigger compensatory mechanisms, such as increased sympathetic activity or hormonal release, that paradoxically worsen blood pressure and further tax the heart. Thus, the relationship between hypertension and heart failure is both direct and cyclical. Chronic high blood pressure initiates heart damage, which in turn exacerbates blood pressure regulation. Recognizing this interconnectedness is crucial in selecting the right treatment strategies, especially medications that go beyond simple pressure control to target the underlying pathological processes. Pharmacologic treatment, more than just blood pressure reduction. Hypertension treatment is rarely a one-size-fits-all endeavor. Several classes of antihypertensive medications not only lower blood pressure but also address the structural and biochemical pathways involved in hypertensive heart disease. These medications are often used in heart failure management as well, highlighting their broader role in cardiovascular protection. Angiotensin-converting enzyme, ACE, inhibitors. ACE inhibitors, such as lisinopril and enalapril, block the conversion of angiotensin I to angiotensin II, a potent vasoconstrictor, a substance that narrows blood vessels. By lowering angiotensin II levels, these drugs reduce arterial tension and blood pressure, promote sodium excretion, and lower aldosterone production. Importantly, ACE inhibitors also limit or reverse cardiac remodeling and fibrosis, preserving heart function in patients with or at risk of heart failure. They also slow the progression of kidney disease, particularly in diabetics. Angiotensin II receptor blockers, ARBs. ARBs, like losartan and valsartan, block the angiotensin II receptor directly, achieving similar effects to ACE inhibitors but often without side effects like persistent cough. ARBs are particularly useful in patients who are intolerant to ACE inhibitors, and they are also protective against cardiac and renal complications. Beta blockers. Drugs like metoprolol and carvedilol reduce the heart's workload by blocking beta-adrenergic receptors, part of the body's adrenaline response. This lowers heart rate, decreases myocardial oxygen demand, and dampens sympathetic nervous system, which controls the fight or flight response activity. Beta blockers are critical in managing heart failure with reduced ejection fraction, post-heart attack care, and in some forms of arrhythmia. In hypertensive patients with these comorbidities, beta blockers offer dual benefits. Calcium channel blockers. These medications, such as amlodipine and diltiazem, relax the vascular smooth muscle by inhibiting calcium influx. The result is vasodilation and reduced systemic vascular resistance. Non-dihydropyridine variants, like verapamil and diltiazem, also slow heart rate and are used in arrhythmia management. Calcium channel blockers are particularly effective in older adults and Black patients and can be safely combined with other antihypertensives. Diuretics. Often termed water pills, diuretics promote the excretion of sodium and water by the kidneys. This reduces blood volume and venous return, thereby decreasing cardiac output and arterial pressure. Thiazide-type diuretics, e.g., hydrochlorothiazide, chlorthalidone, are especially effective in salt-sensitive hypertension, which is common in elderly and African American populations. Loop diuretics, e.g., furosemide, are more potent and often reserved for cases of fluid overload, such as in heart failure. Emerging therapies, newer medications, such as SGLT2 inhibitors, initially developed for diabetes, are showing promise in heart failure and may play a future role in select hypertensive patients. Additionally, device-based treatments like renal denervation are being investigated for resistant hypertension. Sodium and blood pressure, a fundamental but misunderstood relationship. A central concept in hypertension is the impact of sodium on blood pressure regulation. When sodium intake is high, the body retains more water to dilute it, expanding blood volume. This volume expansion raises blood pressure by increasing the pressure inside arteries, much like adding more water to a closed plumbing system. The paradox of sodium testing in hypertension. Despite sodium's role, routine blood tests often fail to reflect high sodium intake. This is because serum sodium concentration is tightly regulated by the kidneys and various hormonal systems. Even when someone consumes a high sodium diet, the body will usually adjust by retaining more water, thus maintaining a normal sodium concentration in the blood. As a result, normal sodium levels on a blood test do not rule out dietary sodium as a significant contributor to hypertension. Physicians instead evaluate dietary patterns, urine sodium levels, in some cases, and clinical response to sodium restriction when assessing the role of salt in a patient's condition. Diagnosing the type of hypertension, primary versus secondary. Primary, essential, hypertension. This is the most common form, accounting for 90 to 95% of cases. It develops gradually and is influenced by genetic predisposition, age-related arterial stiffness, excess sodium intake, obesity, lack of physical activity, excessive alcohol use, chronic stress. In this category, no single identifiable medical cause exists, but multiple risk factors contribute. Secondary hypertension. This form, though less common, is crucial to identify because it can sometimes be cured or significantly improved by treating the underlying cause. Secondary hypertension results from identifiable disorders, including chronic kidney disease, renal artery stenosis, primary aldosteronism, excess aldosterone, pheochromocytoma, adrenal tumor, hypothyroidism or hyperthyroidism, obstructive sleep apnea, certain medications, e.g., NSAIDs, steroids, decongestants. Treating the person, not just the pressure. High blood pressure is often called the silent killer, for a reason. It usually doesn't cause obvious symptoms until it has already inflicted significant damage on vital organs like the heart, brain, and kidneys. Similarly, early stages of heart problems, such as enlargement of the heart muscle or even subtle scarring, can exist quietly, without warning signs like chest pain or shortness of breath. For many individuals, the only clear indicator of a problem is a high blood pressure reading itself, often discovered during a routine checkup. When a healthcare provider prescribes a medication, like a diuretic, and the blood pressure numbers drop into a healthy range, it naturally feels like a success. The patient often feels no different, or perhaps better from a perceived relief. The doctor sees the numbers improve, and the immediate risk of a severe blood pressure spike is reduced. However, this seemingly positive outcome can hide a dangerous reality. Masking deeper issues. If high blood pressure is primarily caused by an unaddressed underlying condition, such as a narrowed kidney artery, undiagnosed sleep apnea, or a subtle hormonal imbalance, simply lowering the blood pressure with medication doesn't fix the core problem. The damage related to these specific root causes might continue to progress, even if the blood pressure numbers look good. For example, a water pill won't clear a blocked artery or stop a tumor from producing excess hormones. Missing a chance for a cure. Many underlying causes of high blood pressure are actually treatable, and sometimes even curable. If healthcare providers focus solely on managing the symptoms, like high blood pressure, without a thorough investigation, the opportunity to find and address the true cause is lost. This can delay the most effective, targeted treatment. Unnecessary risks from medications. Any medication comes with potential side effects. Diuretics, for instance, can lead to dehydration, electrolyte imbalances, such as dangerously low potassium, and may worsen conditions like gout or diabetes. These risks are acceptable when the medication is directly addressing the core problem, but they become concerning if it's merely a superficial fix, exposing patients to risks without fully resolving their health challenge. Short-term satisfaction versus long-term health. Patients, understandably focused on seeing their numbers improve, might feel satisfied and less motivated to undergo further tests or make complex lifestyle changes. This short-term satisfaction could inadvertently compromise their long-term health if the true underlying cause remains unaddressed. Healthcare professionals are trained to navigate this complex challenge. They look for red flags, such as very high blood pressure at a young age, blood pressure that's difficult to control with standard treatments, or unusual lab results. When these signs appear, they trigger a more in-depth search for underlying causes beyond routine screenings, involving specialized tests like blood hormone levels, urine collections, or imaging scans. Modern guidelines and personalized treatment. Modern guidelines for primary hypertension don't always start with a diuretic as the sole initial choice. According to the latest recommendations from the American College of Cardiology, ACC, the American Heart Association, AHA, and the 8th Joint National Committee, JNC8, treatment should be personalized based on age, race, coexisting conditions, and cardiovascular risk. Recommended first-line options include ACE inhibitors, e.g., lisinopril, enalapril, ramipril. ARBs, e.g., losartan, valsartan, olmesartan. Calcium channel blockers, e.g., amlodipine, diltiazem, verapamil. Thiazide-type diuretics. For Black adults without chronic kidney disease, thiazide diuretics or calcium channel blockers are often preferred. In patients with diabetes or kidney disease, ACE inhibitors or ARBs are favored for their protective effects. Beta blockers and loop diuretics are more commonly used when specific indications such as heart failure, post-myocardial infarction care, or arrhythmias exist. The target blood pressure for most patients is less than 130/80 mmHg, especially in those with high cardiovascular risk. However, overtreatment, particularly in older or frail patients, can cause harm, and therapy should always be tailored accordingly. Overtreatment, pushing blood pressure too low, especially in older or frail patients, can lead to several serious risks and complications. Here's a breakdown of the potential harms. 1. Hypotension, low blood pressure. Can cause dizziness, lightheadedness, fainting, or falls, particularly dangerous in the elderly. Falls may lead to fractures, head trauma, or hospitalization. 2. Orthostatic hypotension. A sudden drop in BP upon standing, common in the elderly. Increases risk of falls and impairs mobility. 3. Reduced blood flow to vital organs. Overlowering blood pressure can impair perfusion to critical organs like brain. Risk of confusion, cognitive decline, or ischemic stroke, especially in patients with carotid artery disease. Heart may worsen angina or lead to myocardial ischemia. Kidneys can cause acute kidney injury, especially in patients with pre-existing kidney disease or bilateral renal artery stenosis. 4. Electrolyte imbalances and drug side effects. More aggressive treatment often means multiple medications, which increase the risk of electrolyte disturbances, e.g., low sodium, low potassium. Raise the risk of drug interactions or adverse effects like bradycardia, fatigue, or kidney dysfunction. 5. Decreased quality of life. Symptoms from low BP, e.g., fatigue, weakness, dizziness, can interfere with daily activities, reduce independence, and lower overall quality of life. The role of diuretics, a double-edged sword. While diuretics are valuable and often essential, particularly for hypertension and heart failure, giving them to a patient whose high blood pressure is not primarily driven by fluid retention or excess sodium can indeed cause new problems or worsen existing ones. Exacerbating dehydration. If the patient's blood pressure is high due to issues like narrowed arteries or an overactive nervous system, and not primarily excess fluid, a diuretic will still remove fluid, leading to an excessive reduction in blood volume. This can cause hypotension, low blood pressure, leading to dizziness, lightheadedness, or fainting. Acute kidney injury, aka too much fluid loss, can reduce blood flow to the kidneys, potentially causing a sudden kidney injury that is usually reversible but can be serious. Electrolyte imbalances. Diuretics can disrupt the body's balance of essential electrolytes like potassium, magnesium, and calcium. Low potassium, hypokalemia, is a common side effect and can lead to muscle weakness and dangerous irregular heart rhythms. Worsening other conditions. Diuretics can sometimes increase uric acid levels, potentially triggering gout attacks, or raise blood sugar, making diabetes harder to control. Despite these potential risks, diuretics remain a cornerstone of hypertension treatment. For most individuals with primary hypertension, there's often some degree of subtle fluid retention that diuretics effectively address. They are also highly effective and cost-efficient, with a strong evidence base for reducing serious cardiovascular events. The key lies in careful patient selection and continuous monitoring of blood pressure, kidney function, and electrolytes once therapy begins. The role of lifestyle in lifelong management. While medications are crucial, lifestyle modifications remain the cornerstone of hypertension prevention and control. Effective non-pharmacologic strategies include dietary sodium reduction. Target less than 2,300 milligrams per day, ideally less than 1,500 milligrams for high-risk groups. Regular exercise, at least 150 minutes of moderate intensity activity per week. Weight loss, even modest reductions can lower blood pressure significantly. Limiting alcohol, no more than 1 drink/day for women or 2 for men. Smoking cessation and stress management, both improve cardiovascular outcomes. Patients who commit to these changes often find that they can reduce or even eliminate their need for medication over time. Conclusion: beyond the numbers. Hypertension is more than a numerical diagnosis, it's a window into a person's cardiovascular health and future risk. Effective management requires going beyond symptom suppression to uncover underlying causes, monitor organ function, and deploy treatments based on each individual's needs. Whether through medication, lifestyle change, or advanced diagnostics, the goal is the same: to preserve heart and vascular health, prevent complications, and ensure quality of life. By focusing on the whole patient rather than the blood pressure reading alone, healthcare providers can offer care that is not only effective, but enduring.